we could go to the second page of the PDF, and you see that it says National Target Drug Good Faith Dispensing Policy.
Yes,
Have you reviewed this policy?
I have.
Okay, and I really only want to ask you about one piece of it. I think it's previously been discussed by other witnesses. What I wanted to talk about is on page 18 of the PDF, towards the bottom, the second to last bunch of bullets where it says interpretation. So just starting at the top, it's talking about the visual system. It says it involves 5 components for helping pharmacists classify patients by risk. And I want to talk about one, interpretation there. So the question asked for the pharmacist is, or do I now feel comfortable allowing this person to have controlled substances? And the 2 bullets say, use a brief questionnaire available online, such as the opioid risk tool, or screener or opioid assessment for patients in pain to predict misuse or abuse by patients. Are you familiar specifically with the opioid risk tool?
I am.
And is that one of these opioid risk assessors that you just described to us?
Yes, so the opioid risk tool has been one of the most commonly used little mini surveys that's supposed to predict if the patient will get addicted or not. It's widely used still today.
And how did it come into being? Are you familiar with that?
Yes, the doctor who invented the opioid risk tool, his name is Dr. Lynn Webster. He is a well-known key opinion leader, meaning that pharmaceutical companies paid him to influence the medical community. He invented the opioid risk tool. He also ran his own pain clinic where he had many patients on high doses of opioids, and where many patients lost their lives to overdoses, which led the DEA to actually shut down his medical practice. He, however, still invented this tool that supposedly predicts addiction.
I mean, does it work? Is there evidence showing that you can do this?
So it was studied to see whether or not this opioid risk tool can reliably predict addiction, and it was proven not to work.
In your view, is there some sort of problem with telling pharmacists to use such a tool?
Yes, well, for one thing, it doesn't work. The other thing, the idea behind this tool is, and the message that pharmacists were hearing, and that the medical community was hearing, is that the drugs themselves are not inherently addictive and risky. There's just some people out there that are prone to addiction, and there are some risky patients out there that we have to be careful about. And if we use the opioid risk tool, we can find these risky people, maybe be more careful with them, and everybody else can get as much opioids as they want. When in reality, the issue is not that there are some risky people. The issue is that the drug is inherently risky.
Right above that statement, there's a statement about generalization. It says, do we agree on mutual responsibility and expectations? Use statements with patients such as, I am your pharmacist and I agree to promptly and respectfully provide medications and services if certain rules are met. And then it lists things the patient can agree to, such as not sharing medications, agreeing to only use one pharmacy to fill controlled substances, and agreeing that the prescriber can be contacted if refills are too early. It seems logical to have such an agreement with patients. Is there any problem that you see with that?
Like much of this, it sounds good. So a patient agreement, the way these work is that at a pain clinic or a doctor who does lots of opioid prescribing, the idea was that the patients who are going to get all their opioids from the doctor's office, the patient signs an agreement. And the agreement says, I promise to only go to one pharmacy. I promise to only get my narcotics from one doctor. I promise to take my medicine exactly as prescribed. All of these promises. And the patient signs it, and it's called a patient prescriber agreement. The problem with the agreement is that if the patient becomes addicted, the fact that they promised that they were only going to go to one pharmacy is sort of meaningless. Once they're addicted, especially if they're losing control of their use, once their addiction is severe, it won't make a difference that they signed this. They'll continue to seek opioids. And if the patient was already addicted when they came to the doctor, and so they were visiting the doctor because they needed to maintain their supply, and the doctor gives them a form to sign that with all these promises, they're going to sign whatever they need to sign to get their prescription. Somebody who's addicted may forge prescriptions, engage in illegal behavior. Signing an agreement that I'll only visit one pharmacy, no problem. Of course they'll sign it. So the agreements don't do anything to actually protect a patient. What they serve is as protection for the doctor. So let's say the patient dies of an overdose and the family wants to sue the doctor. The doctor can pull out the form and say, hey, it's not my fault the patient died. They promised they were only going to go to one pharmacy, one doctor. Look, they broke all of the rules. Can't blame me. So it serves to protect the doctor, but it's pretty useless for protecting a patient.